Hi, my name is Dr. Thierry. I'm a medical doctor at the Lorient General Hospital in France, and I'm very pleased to present you our study for this 12th International Association for Advancement of Space Safety Congress in Japan. The topic of this research is advanced airway management in weightlessness, and especially we focused on orotracheal intubation. Orotracheal intubation is a very difficult, invasive and specialized procedure which allows to secure oxygen supply to the lungs and to protect the lungs from gastric aspiration. Intubation is a time-pressured procedure for which side effects and complications may be life-threatening. This means that performing orotracheal intubation in any conditions that are less than optimal is really dangerous. In the case of long-duration space flights to the Moon or Mars, potential medical emergencies are numerous, such as highlighted by prediction models provided by space agencies, with some scenarios requiring the need for oxygen support, artificial ventilation, and orotracheal intubation. We can cite examples of cardiac arrest, decompression sickness, or general surgery, all of these diseases that would require orotracheal intubation. Managing orotracheal intubation in weightlessness can be really difficult due to ergonomic constraints. Recent studies show us that weightlessness can lower the probability of first-pass success and can delay the time to first ventilation. In this context, maintaining orotracheal intubation capabilities can raise technical and ethical issues. But we believe that orotracheal intubation in weightlessness could benefit from updates due to new material, new concepts coming from terrestrial pre-hospital medicine. You should know that a free-floating intubation can be really dangerous in space due to high failure rates, which prohibits its implementation in a space environment. We hypothesized that two intubation configurations in free-floating could still offer safe outcomes. So we tested two positions. To be considered as safe, each technique had to reach a 95% success rate for first pass. Below this threshold, the technique would become unsafe for space implementation. Now, the first technique we used was using a video laryngoscope at the head of the mannequin with a free-floating expert operator. The second condition was still with a mannequin, but this time with a classic direct laryngoscopy with a free-floating operator in a very special position which we call the ice-pick position, or also known as face-to-face. It's a very special position that you can sometimes find in pre-hospital settings, especially when you don't have access to the head of the patient, when your patient is in a car or in a narrow recess. This study took place on board the Airbus A310 during a parabolic flight campaign from the French National Space Agency. Each parabola consisted of about 22 seconds of hypergravity at 1.8 g, during which the plane accelerated upwards at a 45-degree angle, then about 22 seconds of free falling in the parabola, followed by another period of hypergravity corresponding to the recovery of the plane to the starting altitude. 3 flights were conducted, each flight offering 30 parabolas. We tested these two conditions under 2 gravity conditions, in weightlessness and in normal gravity. The main finding of our study is that none of the 2 tested conditions could meet the minimum safety standards. In the first experimental conditions, experts used video laryngoscopy at the head of the mannequin in a free-floating position. Unfortunately, they had only a 57% success rate, which is not suitable with safety standards. Now, in the second position, it was even more difficult for experts to have success intubations. We have only a 33% success rate, which is really low. Free-floating intubation is really dangerous for patients in space. Combined with existing literature, this result suggests that performing endotracheal intubation under postural instability with conventional direct laryngoscopy is difficult, even for trained experts. Space intubation should be performed only if the 3 conditions are reunited. The procedure has to be led by an expert, has to be performed under restrained conditions, and with a video laryngoscope. Any other configuration imposes operator to switch to other devices such as supraglottic airway devices. Thank you for your attention. We would like to thank the CNES, which is the French National Space Agency, the Lorient Hospital for their support, and Novespace for helping us implementing this experiment in the plane. If you want to have further information, you can find additional data in the final publication.